Our next topic is accelerated hypofractionated chemoradiotherapy followed by SABR boost for locally advanced unresectable. Yeah, it's not visible. Prospective phase 2. The limited advances were seen prior to the Pacific trial for unresectable stage 2-3 non-small cell lung cancer in the last decade. From the 1980s to the 2000s, the trials conducted like CAL-GB8433. The single-agent chemotherapy was compared with the double agent as seen with the etoposide cisplatin in the SWOG 9019 trial. The induction versus induction and sequential chemoradiotherapy was seen compared in the RTOG 9410 trial, based on which it was established that the concurrent platinum doublet concomitant chemoradiotherapy was to be given as the standard of care with the dose of 60 to 63 gray. From the 2008 previous slide. From the 2008 to 14 to 15 to 16, various schedules was comparing the consolidation versus maintenance chemoradiotherapy until in 2017-18, where the concomitant chemoradiotherapy was given followed by the maintenance durvalumab in the Pacific study. Next. The hypothesis and rationale for this was the medically inoperable stage 2 and 3 non-small cell lung cancer was included. The local control was still 50 to 60% and the survival was poor prior to the Pacific trial. The dose escalation beyond 70 gray with protracted approach is detrimental in the randomized cooperative phase 3 setting. The hypothesis behind this was applying the technical advances of SABR with hypofractionation. It had a thoughtful margin design, reduced toxicity, improved outcomes, and the shortened treatment course. Now the study schema behind this hypofractionated chemoradiotherapy followed by SABR boost. The patients were enrolled who were biopsy-proven stage 2 to 3 with no history of prior radiotherapy. The simulation was done and the patient was prescribed with the dose of 4 gray in 10 fractions boost, followed by which at the 8th or 9th fraction resimulation was done and the dose escalation cohort was given like 5 gray in 5 fractions boost or 6 gray in 5 fractions or 7 gray in 5 fractions. The majority of the patients, like 64%, were of the adenocarcinoma variety, while 36% were of squamous cell carcinoma, and the median follow-up was 16.9 months. The normal tissue sparing strategy with the DVH goals as the dose prescribed to the PTV, the V100% was 95%. The mean dose to the esophagus was less than 34 gray and it was achieved as 14.14 gray. V75 gray for trachea and bronchial tree less than or equal to 10 ml, achieved was 0. The mean dose to the heart less than or equal to 30 gray. The total lung PTV1 V20 less than 40%, mean dose less than or equal to 20 gray. Skin V75 less than or equal to 5 ml, spinal cord maximal dose less than or equal to 40 gray. Brachial plexus V65 gray less than or equal to 5 ml. Now the various patient and treatment characteristics were included based on the low, intermediate and high dose cohort. The median age was approximately 70 gray in all of these, with the majority being the male gender, and the KPS median was 80. The adenocarcinoma variety included 64% as a total, with the 36% in the squamous cell carcinoma. The majority of the patients in the total category belong to the stage 3A and 3B, with a median follow-up being the highest in case of the intermediate cohort. The total dose was 65 gray, 70 and 75 gray in the low, intermediate and high cohort respectively, and the number of fractions given were 15. The consolidative treatment was 20 with paclitaxel was 21%, while with the durvalumab was 4%. Now this is an image showing the patient with the stage 3 adenocarcinoma left upper lobe lung. Initially the patient is given 4 gray in 10 fractions with the PTV margin of 5 mm. And you can see the PET-CT response after 40 gray, for which patient is provided with the SABR boost with the 6 gray in 5 fractions to the IGTV only. Now the dosimetric gains with the PET-adaptive SABR boost was seen in case of the adaptive plan sum as compared to the initial plan. with the dose comparing as seen in case of the lung, the esophagus, and to the bronchus. This is an image showing the response assessment with the initial hypofractionated followed by the boost in case of the patient after the boost therapy. Now we have a Kaplan-Meier curves to compare the local control, progression-free survival, and the overall survival. Next. The disease control was as compared of the low dose cohort was compared with the intermediate and high dose cohort. The local control was more in case of the intermediate and high dose cohort as compared to the low dose boost. And the progression-free survival was initially more in case of the low dose boost. However, later on it was more or less similar with no significance. The overall survival was seen to be more in case of the intermediate or high dose boost cohort.
One more minute to conclude.
Okay. Coming to the summary, the local control was seen to be more in case of the intermediate and high dose cohort. The median progression-free survival was more in intermediate as compared to the low dose cohort, and the median overall survival was more in case of the intermediate and high dose cohort. Now this is the bar graph showing the acute toxicities. It was seen that in case of the low dose boost, the grade 1 and grade 2 toxicities were more. However, the grade 3, 4 and 5 were more with the high dose boost. The late toxicities were grade 1 and grade 2 with the low boost. However, with the grade 3 and 4, 5, the high toxicity was seen with the high dose boost. The various serious treatment-related adverse effects, the acute being with the less than 90 days post-RT were pulmonary toxicity, radiation, dermatitis, and sepsis. The late ones including the pulmonary toxicity, esophageal stenosis, stricture, and sepsis.
Can you come to the summary slide, please?
Yes, just the last one. Now coming to discussion, to our knowledge, this trial utilizes one of the most aggressive hypofractionation regimens studied in SABR boost with the various treatment planning and HyCRT strategies. The specified maximum tolerated dose was not reached. However, the patients who were treated with 73 and 15 fractions had the most favorable outcomes. Overall safety profile, efficacy, and convenience for this regimen appears promising. Further improved outcomes may be achievable utilizing this regimen as the backbone in combination with the novel drugs and immunotherapy. Thank you.